Hello, everyone. So welcome. It's great being back online. We've had a couple of months off with ASCARs and a few public holidays, but we're back and we have a fantastic session today. This is our team, of course. Dr. Galandiak is the editor-in-chief. This is our disclaimer, so that's quite straightforward. We have a fantastic session, as I've mentioned today. Our viewers may remember that we try to have an international event once a year, and we've had a few great ones from Brazil, UK, Portugal, Dubai, and now Italy. And I'm particularly grateful for Dr. Caterina Foppa and Dr. Carvello, who really supported this from the local Milan faculty. And so we'll get them to introduce their city and their institution. And before we do that, just a brief sort of interesting fact, which I try to do. And one of the things that I found out in Milan, and of course, there are many amazing things in Milan, but what I've learned was that there is a hospital called the Ca Granda, and it is one of the oldest hospitals in Italy, founded in 1456, and it has an interesting Renaissance architectural design. But what is unique from a medical perspective, that it was, I think, one of the first hospitals that separated patients by gender and medical condition. And so it was a pioneering institution in terms of hospital organization and specifically hygiene. And so that was, I think, built in 1456. So I think that's amazing and shows what history Milan has medically. So now I'd pass on the microphone to either Caterina or one of the other panelists to talk about their city. Thank you.
Thank you, Vladimir. We are delighted to host the DC&R Journal Club here at Humanitas Research Hospital in Milan. So let's start with a brief description of our city, Milan, which is not just an Italian city, but the true Middle European heart. It's the capital of Lombardy region and the financial core of Italy, home to the Italian Wall Street and major global brands. Milan perfectly blends history and innovation, from Leonardo da Vinci's Last Supper, you can see it top right, to the majestic Gothic Duomo, topped by the Golden Madonnina, to the modernity of beautiful skyscrapers. It's also a global capital of fashion, hosting the prestigious Milan Fashion Week and Design Week, and housing iconic brands like Prada, Armani, and Versace. Via Monte Napoleone is one of the most luxurious shopping streets on the planet. And then there is the food, the iconic golden crispy veal cutlet, but you can see it on the right, but also Milanese risotto with saffron, and the beloved apericena, a Milan-born fusion of aperitivo and dinner, a way of living in the busy Milanese routine. Looking ahead, Milan is preparing to co-host the 2026 Winter Olympics together with Cortina d'Ampezzo, which is a city on the Dolomites. And this is our hospital. Humanitas Research Hospital is a private public hospital located in Rozzano, which is a small village just outside the southern boundary of Milan. The hospital was founded in 1996 with the purpose to combine the healthcare and research. It's internationally renowned for integrated advanced clinical care, biomedical research, and medical education within a single patient-centered environment. Humanitas is structured around 4 highly specialized clinical areas, each offering multidisciplinary high complexity care. These are cardio, neuro, ortho, and cancer center, which includes also our division of colon and rectal surgery. And the Cancer Center is a comprehensive oncology center integrating medical, surgical, and radiation oncology with molecular diagnostic and clinical trials. In 2002, Humanitas became the first hospital in Italy to be accredited by the Joint Commission International and is regularly ranked among the top hospitals in Italy and in the world for clinical performance. But Humanitas is also an academic hospital. Humanitas University was founded in 2014. It's a private international institution with around 2,700 students enrolled across 7 medical degree programs. Among these, 2 are English programs, the medical school, and the newly established MedTech school, which combine medicine and biomedical engineering in partnership with the Politecnico of Milano. The university hosts also 26 residency programs. Among these, there's also a general surgery program and several PhD courses. The campus has also a simulation and an innovation building, as well as an experimental skill labs with the VR simulator for training. And this is our division, the Division of Colon Rectal Surgery, directed by Professor Spinelli. The division was born in 2015 and currently performs over 700 major colorectal surgery per year. Of these, 200 are rectal resections, covering all the colorectal benign and malignant diseases. Professor Spinelli, you know, it's also the current ESCP president, is internationally recognized for his expertise in colorectal surgery, particularly rectal surgery, making the division a reference center for advanced training and surgical education. The division is also distinguished by its comprehensive use of minimally invasive approaches supported by cutting-edge technologies, including laparoscopy, robotic, single port, both laparoscopic and robotic, and transanal minimal invasive techniques. In parallel, the division maintains a strong commitment also to clinical and translational research. In fact, we have a clinical trial unit and currently about 50 ongoing studies. So this is today's local faculty. Here with me there are Dr. Michele Carvello, Dr. Leandro Siragusa, Elisa, Paoluzzi, Tomada, and our special guest, which is Professor Cesare Hassan. Professor Hassan is a professor of gastroenterology here in Humanitas and current president of ESGE. As you can see from this brief bio sketch, Professor Hassan has a distinguished career with extensive expertise in the field, particularly in colorectal cancer prevention, endoscopic innovations, and training. His research has made a significant impact over the years, and we are truly honored to have him with us today. But beyond his greater career and expertise, I'd like to share a little story that adds a personal touch to his connection with the DCR journal. Professor Hassan has been a dedicated reader of DCR for many years, and in fact, one of his very first publications as first author was in DCR back in 2005. That article focused on cancerized polyps, which continues to be one of his main research interests to this day. So it's quite special to have him here, not just as an expert, but also as someone whose academic journey has been very close tied to this journal.
Thanks, Caterina.
Thank you. I think that's wonderful. And I think from our perspective, it's truly unique to have the authors of the article being also the presenters. And so we have both the articles today, which are from the local faculty. And I guess I have one question about fashion in Milan and whether you have fitted scrubs which are perfectly suited to your body shape, because I find in Australia at least the material is quite poor and they're very baggy. So perhaps you have fashion everywhere, even in the OR. Now, on this note, if we can please have the presenter for the first paper. So the paper is called Postoperative Complications that are Associated with an Early and Increased Rate of Disease Recurrence After Surgery for Crohn's Disease, published in 2022, with Dr. Siragusa and Dr. Carvello making comments. Thank you. Please start when you're ready.
Hello, everyone. First of all, I would like to thank you for the kind invitation and presentation. In Greek mythology, Achilles was almost invincible, except for his ill. In Crohn's disease management, we are not invincible, but we have many therapeutic weapons, drugs, biological agents, surgery. Still, the true Achilles heel remains recurrence. In fact, despite surgical resection, around 2/3 of patients develop endoscopic recurrence within 1 year, and half will require a reoperation in the following decade. We know some risk factor, young age diagnosis, penetrating or perianal phenotypes, but these are not modifiable. Smoking is the only one. Importantly, recurrence is not just a single event, it's a multidimensional process, and what we call surgical recurrence is only the tip of the iceberg. Next. Underneath, in fact, we have immunohistological recurrence, which is often the earliest sign, endoscopic recurrence, often silent but indicating biological active disease, defined with Rutger score above I2, meaning anastomotic lesions or more than 5 afters ulcers, and finally clinical recurrence, marked by the return of symptoms. So how can we survive the jungle of Crohn's disease recurrence contradiction? Because indeed, the surgical strategies are debated and often contradictory. For instance, let's take the mesentery management. Spicy trials show no difference with mesenteric excision, while the mesocolic one, on the other hand, suggests that including the mesentery may reduce endoscopic recurrence. Regarding the anastomotic configuration, we are now debating between CONOS, side to side, but early results from international trials show no difference so far. And another ongoing trial comparing CONOS end-to-end and side-to-side still pending. And then the paradox. If mesentery and anastomosis matter so much, why does stricturoplasty, which involve neither, still heal, suggested by some studies, both bowel and mesentery? So here, the mythological images of Sisyphus, the king condemned by the god to roll a boulder uphill each day, only to see it fall apart and start over. Surgery for Crohn can feel just like that. We treat, we resect, restore, and yet the disease recurs, sometimes silently, sometimes more aggressively. So, given the lacking of evidence, the study aimed to assess whether postoperative complication might be a factor contributing to recurrence after ileocecal resection. That was a retrospective multicenter case control study conducted in 2 tertiary IBD centers, including all patients who underwent ileocecal resection between 2008 and 2018, with at least 24 months of follow-up. Recurrence was defined as Rutgers above I2, CDIA above 150, and of course reoperation. And recurrent patients were compared with no recurrent one. And we collected data on demographic, perioperative data, and of course the follow-up. Out of 305 patients, 43 were excluded and 262 analyzed, 117 non-recurrent against 145 recurrent. On the right, you can see that, as expected, penetrating phenotype and perianal involvement were significantly more frequent in the recurrent group. Now, looking at outcome, there was a statistically significant difference in the rate of overall postoperative complication between groups. However, when analyzing specific type of complication, no category reached statistical significance, likely because underpowered due to the limited sample size for that particular outcomes. And importantly, there was no association between recurrence and surgical approach and setting, and anastomotic type or configuration. Therefore, we performed a multivariate analysis complemented by Kaplan-Meier curves, exploring both endoscopic and clinical recurrence in relation to the presence or absence of postoperative complication. And both penetrating disease behavior, as expected, but also postoperative complication were independent predictor of endoscopic and clinical recurrence, respectively, with an hazard ratio of 145 with a p of 0.03 for endoscopic recurrence and 165 with a p of 0.04 for clinical recurrence. So, to conclude, postoperative complication affect long-term outcome in ileocolic surgical Crohn's disease patient and possibly lead to an increased and early disease recurrence rate. We have talked before earlier about risk factors, that most of them are not modifiable, but indeed surgical complications are, and that's exactly where we as surgeons can act. So if we want to break the Sisyphean cycle of recurrence, being endlessly trapped in the same pattern, we must start from what we can actually control, avoiding complication and improving the quality of surgical care. Of course, this study must be validated by further prospective studies, also looking at the specific risk based on complication types.
Thank you very much. That's a wonderful summary, and I completely agree with your views in terms of, the different debates on which option of an anastomosis is better, how much mesentery to take is better, yet sort of neglecting the fundamental of surgical complications. Can we please get Dr. Carvello to comment about sort of your opinion on the study, and also, I guess, the insight into publishing the study and what challenges you may have had from a practical perspective of getting it through? Thank you.
Thank you. It is a great pleasure to participate to this journal club today. So this study actually, as Leandro said before, comes out of to survive the jungle of contradiction. And every day we struggle to find which is the best way to reduce recurrence, because we are surgeon. We try to put things together in the most practically way we have. So we started to think, maybe if we do our job in the best way we can reduce the recurrence. And if we believe the message of this study, which means that complications are not just detrimental in the short term, but also in the long term, we need to redesign completely the surgical pathway of these patients. For example, if we want to really reduce the complication, we need to prepare the patient in terms of prehabilitation. For example, we need to bring up the nutritional status of the patient. That is the way to reduce complication, because sometimes it is the best center in the world, but if you have the worst patient in Earth, then he's going to have postoperative complication. Then if we redesign the clinical pathway, surgical pathway, we need to centralize surgery. We at some point probably we cannot do even the simple ileocecal resection in the spoke center. We need to bring everything in the hub, because everything has to be as smooth as possible, as routinely feasible as possible. That is how we reduce complication. And then the other thing is that we need to bring the surgical step at an earlier stage of disease, because we know the longer we go, the later we act in the disease course. In Crohn's disease, the more we're going to have a complex disease to face, a longer operation, more chances of postoperative complication, more chances to get a penetrating disease, and that means also more chances to get postoperative complication. Then the other thing is that for the very first time, we have a modifiable factor in terms of a risk for disease recurrence, firstly in the hands of the surgeon, because the other factors, as Leandro said before, are penetrating disease. We cannot do anything about this. This is the disease behavior, and this is not dependent on the patient, not dependent on the clinician. Smoking is an important risk factor, but that is patient dependent, so we cannot do really anything about it except for anti-smoking campaign, for example. But now we have something that we can manage, so reduce postoperative complication rate.
Thank you. I guess one of the things that I am wondering based on this study is, well, two things. Firstly, the pathophysiology of why you think the complications linked. But secondly, if the complications are linked to recurrence of disease, what is your view of fecal diversion? Do you advocate for more diverting proximal stomas in order to reduce the potential complications and therefore reduce the recurrence of disease that way?
Okay. So can you repeat the first point, please?
I guess the first part is, do you have a hypothesis of why it's linked?
Okay, this is a very interesting point. That is the point, actually. We know we are dealing with a really, really complex disease. So all the immune system of the patient with Crohn's disease is completely altered during their lifetime and during surgery. I believe that if anyone here has been dealing with the Crohn's disease, they know that after surgery, for example, they have this skyrocketing CRP, for example, and they're doing completely fine. So there's something going on with their immune system. If anything goes beyond the standard clinical pathway, the uneventful clinical pathway, this, I think, we believe is going to do an inception on the immune system, and then it's going to be an immune system reaction in terms of long-term recurrence. So this is how we think as the mechanism. The second point was on fecal diversion. This is an important point. Of course, we cannot do fecal diversion in all patients we operate to reduce complication, of course. So we are trying, of course, to select patients to give them fecal diversion. Usually we use as a criteria to give the patient the temporary stoma, for example, ongoing abdominal sepsis, poor nutritional status, for example, weight loss of more than 10%. And then if they are using steroids during the surgery. Those are the big criteria that we use.
Thank you. One last question before we move to the next paper, and it goes on to the comment about steroids. In the paper, you define prophylactic treatment as biologics therapy within 3 to 4 weeks of surgery. And so I guess, what is your algorithm of giving biologics to patients with aggressive enteric Crohn's disease? When do you stop, if ever? When do you restart?
Yeah, that's a really interesting point. Usually we decide this by a multidisciplinary meeting. Usually, of course, the gastroenterologist prescribe the drug after surgery. If we want to start earlier, we need to have a risk factor for recurrence. For example, perianal disease, penetrating disease, smoking. Those are risk factors that are the drive for the prophylactic therapy. Otherwise, we do the endoscopy at 6 months after surgery, and then if the patient has recurrence, then we're going to start the immunosuppression or immunomodulation, whatever.
Okay, well, thank you very much for that. In
you.
the interest of time, let's move over to our second paper, and this is a systematic review titled Controversies in IPAA for Ulcerative Colitis, a systematic review of different anastomotic techniques, with Dr. Spinelli being the senior author. This paper it's a unique presentation, as we have the presentation by two of the authors, Dr. Tomada and Dr. Carvello. So Dr. Tomada, please start when you're ready. Thank you.
Good afternoon, everyone, and I would like to thank you for the opportunity to be here today, both my mentor, Prof. Spinelli, and the entire DCR team. And I'm very thankful because I was involved in this paper when we worked on it now 1 year ago with Dr. Kotz and Dr. Avellaneda, and the rest. It was a great international team and work. And so to start with the presentation, restorative proctocolectomy with ileoanal pouch anastomosis, IPAA, is the surgical standard for the treatment of ulcerative colitis, medically refractory, or for dysplasia and cancer in the context of disease, and for patients fit and motivated for restoration of bowel continuity. While the technique for pouch surgery is well established, the type of anastomosis to be performed can impact postoperative outcomes, including complications, cancer risk, and quality of life, and the types can be different. And this brings to the core question of this paper, which is, what is the best anastomosis? In general, we can broadly categorize the different anastomotic types into 3 categories: hands-on IPAA, double-stapled IPAA, and single-stapled IPAA, which actually includes different subtypes: transanal IPAA and the TTSS anastomosis. So the goal of this review was to compare these different anastomotic techniques, starting from the technical characteristics to the main differences in the outcomes and the controversies in the literature. Regarding the methods, back to the methods, please. Okay. This review, the search for the review was conducted on PubMed and Cochrane databases, and the search strategy was with the keywords that you can see here. So from ulcerative colitis, IPAA, transanal, and so on, double staple, single staple, and the exclusion of polyposis. Any study and any type of study regarding the outcomes, but also the description of these anastomotic techniques was included. Studies on patients with polyposis or Crohn's disease were excluded. From the initial search, 350 papers were identified and screened, and then of these, 325 were excluded. After detailed evaluation, 21 articles were included, and an additional 37 studies were included with reference screening. What is very interesting is that with this search, we see the evolution of the anastomotic techniques in IPAA over time. And it was started with an hands-on anastomosis, and the papers that were published on this were before the 90s. Then, starting from the 19th, with the introduction of the double staple technique, more studies were on this technique, but also comparing these techniques with the hands-on anastomosis. And finally, in more recent years, the new techniques with the single staple methods are increasingly studied and are becoming the focus of the literature and the clinical practice. Table 1, just to show just an overview of the studies focusing on the description of the techniques, and mainly single staple and double stapled, and any type of study was reported, from technical reports to observational studies for feasibility and safety of single stapled techniques and double stapled IPAAs. Table 2 shifts the focus to the comparative studies between hands-on anastomosis and the stapled ones. Mostly are studies comparing double staple techniques to hands-on anastomosis, and we can briefly mention the largest and most cited of these studies, which is the one from Cleveland Clinic, published in 2009, analyzing over 3,000 patients and shifting a bit the practice, because it was showing that the double staple technique was associated with fewer complications and better functional outcomes, even in the long-term follow-up, compared to the hands-on technique. The last table, table 3, shows studies comparing double staple IPAA versus single staple IPAA. And these are very recent, starting from after 2015, when the first studies were presented. And there is a growing interest in the single staple techniques, because they showed to be comparable to the double staple techniques, but maybe even showing some potential advantages, especially on the functional point of view. We can take a moment to compare the 3 anastomotic types, having a look at this slide, starting from the left with the hands-on IPAA, which involves a mucosectomy and has been shown to have worse functional outcomes compared to double staple anastomosis, in particular because of the removal of the anal transition zone. Moving to the double staple IPAA, this is currently the most performed, still the most performed procedure for the anastomosis, and it requires the rectal transaction at the anorectal junction with a linear stapler, which though causes the risk of a non-uniform rectal cuff, but still showed improved functional outcomes compared to the hands-on anastomosis. Moving to the single staple IPAA, which, as we mentioned before, includes both transanal approaches and then TTSS, it is increasingly studied and used because of the biggest advantage of avoiding the linear stapling of the rectal cuff of the rectum, and allows for a precise definition of a uniform rectal cuff, which has been shown also by one of the studies from our group to be shorter compared to the double staple IPAA. This comparison highlights how each technique comes with some trade-off of function, risk of cancer also, even though it's very low, even when almost zero when we preserve the rectal cuff, and technical complexity. To conclude, we see that over time, double staple IPAA became the most common technique to be performed, but single staple approaches are slowly taking over because of the advantages that they are bringing, and in particular combining a desire to preserve function for patients on the long term, and avoiding the pitfalls that are intrinsic to the double staple anastomosis. Ultimately, it's always important to remember that we need to select the patients on the basis of the indication and the expertise of the surgeon. Thank you very much. I would like to give the floor to Dr. Carvello to show probably our point of view, the point of view of this institution, our anastomosis.
Yes, but I think we can start with a question from the panel.
Well, one question that I have, and there's out of the attendance, if there's anyone who has questions, feel free to text it into our box. But I guess, and this also is a question for Dr. Hassan as well, from a gastroenterology perspective. So it seems that the incidence of pouches in the world is reducing, probably because the medication seems to be a bit more effective. And I wonder if that means that the patients that ultimately requiring a proctocolectomy and pouch select themselves to be a more aggressive form of ulcerative colitis. And therefore, my question is related to the cuphitis, particularly in the double staple pouch. Do we expect in future to have a higher rate of cuphitis and therefore potentially more cancers in the pouch based on that, because we are selecting more aggressive ulcerative colitis for this operation?
Yeah, so I guess this is a good point because these patients most of the time somewhat escape from endoscopic surveillance. And we had some cases of cancer progression. And I don't get that any of the treatment that we have now for these patients use this risk of progression. So probably we need to do a more effective endoscopic surveillance. But honestly, I don't have any data on the fact that our endoscopic surveillance may be efficient in preventing this type of cancer. So.
Thank you.
Yeah, I had a comment on the fact that we are reducing the surgeries for ulcerative colitis. That's true, completely true, because we have really new drugs, new effective drugs to use for this patient. On the other hand, what we are observing, and are already one study published from the Netherlands, from the group of Amsterdam, that we are experiencing a reduction of the number of colectomy for refractory colitis because we have a better management with drugs. On the other hand, there's an increasing of colectomy and pouches formation for a patient developing dysplasia or cancer, which is the other way to see this this trend. Of course, it is a relative increase, but we need to probably, we are with the new drugs, we are reshaping in some way the disease course. So probably we are selecting the patient that are going through a neoplastic transformation or a degeneration. So that is our take. In our experience in the last 10 years, we have really seen dropping down completely the number of colectomy for refractory disease and going up with colectomy for dysplasia.
Thank you. On that point, in the component of the paper discussing hand-sewn pouches, you mentioned that sort of one of the indication for that is high-grade dysplasia. Now, can you tell me more specifically, are we talking about high-grade dysplasia in the biopsies of the anal transitional zone, anywhere in the rectum? What worries you, and how do you titrate the pouch based on that?
Yeah. So in our experience, and we also published with a couple of years ago on Journal of Crohn's and Colitis, we published a study in collaboration with St. Mark's from London. We published a paper with a patient undergoing pouch for rectal cancer. So we are not afraid basically of the anal transition zone. We are more afraid of high-grade dysplasia in random biopsies, non-visible dysplasia. Those are the enemies that we are facing now. But in these cases, we have our friends endoscopists with AI and endoscopy, and they're really good in finding those little islets of dysplasia even before the histologist. They do frozen section now with the endoscopy. I don't know if Cesare wants to add it on.
I'm not sure that
this
it is
topic, of course.
yeah. I'm not sure it is artificial intelligence, but of course, somewhat to be competent in detecting very flat lesion help in the surveillance of this lesion. I feel it's very operator dependent. It depends on the endoscopist.
I find that in my center, we have AI to help look for polyps, and I'm not convinced that it has helped me find anything meaningful, but I think it makes me be more focused because I don't want to look like a fool for the other people in the room. But do you use it for dysplasia, or is it only for polyps? Because I've never thought about, I mean, I don't scope many patients with dysplasia with UC, but do you actively use that, or is that
No, it is a mistake because the dysplasia in ulcerative colitis is totally different from the somewhat protruded polyps. So there is one randomized trial that showed that AI did very poorly in detection of dysplasia. So I may agree with you that it is questionable whether to use it for standard colonoscopy, but we cannot use this point for detection of ulcerative colitis. But anyway, software trained with ulcerative colitis dysplasia cases are coming, And we're very curious to see if they will impact or if they will avoid chrome endoscopy, because anyway, chrome endoscopy is still time consuming. So if we can avoid thanks to artificial intelligence, this would be at least a step in efficiency, maybe not in efficacy, but at least in efficiency.
Thank you. That's very interesting. I genuinely haven't thought about that before. So that's something to reflect on. Now, I want to ask about the single single anastomosis, the one that you have effectively popularized. Before we get to the technique, and I'm really interested if you can describe it step by step, so hopefully people can, try replicating it. But you mentioned in the paper that a hand-sewn IPAA tends to have a consequence of poorer sphincter function because of the stretch. Now, when we talk about transanal platforms, they don't seem to have the same outcomes, and I'm not sure if that's because we don't measure them, or whether because the stretch is uniform. But what is your take on the impact on the sphincter when you do the sort of single stapled anastomosis?
Yeah, there's an important comment. We believe actually that, I mean, there's a systematic review from Paristekis on this, on hand-sewn anastomosis versus double stapling versus stapling anastomosis. And the rationale why the hand-sewn anastomosis has a worse function than the stapling anastomosis is because when we do the mucosectomy and then we do the pouch anal anastomosis, we get rid of the anal transition zone, which is very, very important for the function. So this is why we believe that the hand-sewn anastomosis perform worse than stapling anastomosis.
Okay, thank you. Now, if it's possible, and there are a few slides, maybe they would help. Can you just describe the steps and the pitfalls of doing the single stapled IPAA, please?
Yes. So if we can go with the slides. So in this slides, you can see all the technical pitfalls in pouch surgery, which are, by the way, all the same mistakes we can do in rectal surgery. So the dissection, transection, and the anastomosis. In the dissection, when we do rectal dissection, is really a nightmare in male pelvis, obese. So it's difficult to do a dissection from below. It's difficult to do dissection from above. But usually when we talk about benign disease, we don't need to do perfect TME in those patients. So we can do what is called a near complete TME or a bad TME. So the dissection is not really a problem in the end, and we can do dissection from above, as we have done for generations, or we can do dissection from below, as we have seen with the transanal approach. But the problem here remains on transection and anastomosis. With transection, especially with the implementation of the minimal invasive approach, we usually need 2 or more firings. That means increased risk of leak. Then we don't have a perfect perpendicular stapling, as you can see, and as you can see on the right side and the middle of the slide. It's really difficult to obtain a perpendicular stapling at that point, and that means we don't have an homogeneous rectal cuff. And in the end, we have a double stapling anastomosis. That means we have dog ears, which are more prone to postoperative leak. Okay. Yeah. And also, as you've probably seen lately in 2021, finally, FDA came out with a warning about the staple line crossing. So it is not forbidden, of course, but it is a warning. Of course, you know that FDA has the control of really everything in the US. So if they came out finally with this warning, there's something really to be worried about the cross stapling. We will see the answer at some point more than 10 years, 15 years ago, was the transanal approach, dissection from above, transection, and anastomosis. However, this type of approach carries some problems in the implementation of this procedure, and most of the problem, urethral injuries, difficulties in finding the plane, came from the dissection, the bottom-up dissection. So at some point we were struggling as most of the time in the dissection, not in the transection and the anastomosis, which were at good point, points of this technique. So we started to think about how can we offer the patient the most important, the most feasible features of this technique, the transaction and the anastomosis. So this is how we came out with TTSS. So we just took the anterior approach to do the dissection, the same dissection, the same approach used from generations of surgeons, proven to be feasible in the open, in the laparoscopic, and in the robotic technique lately, most probably more feasible with the robotic technique. We applied the transanal transaction and the single stapled anastomosis. Transanal transaction means deciding the exact length of the cuff and achieving an homogeneous 360-degree length of the cuff, so not too long cuff anymore, no cuffitis or really controlled cuffitis rate, and better function. You see question mark, but actually we have seen in our data that this type of anastomosis, probably the 3D shaping of this anastomosis, can give the patient a better functional outcome than the double stapling anastomosis. And of course, then we have the other advantage of the single stapling anastomosis with no dog ears, no multiple firings, and so possibly reduction risk of leak.
We have one chat question.
Thank you. I think in the interest of time, because I want to get to Dr. Hassan's interview, I think we'll leave the chat for Twitter.
Yeah.
Sorry to interrupt.
Yeah. We can go to the question now. I will be really happy to take questions.
Okay, well, then we'll leave this as the last question, and then we'll probably move on. And the question from the chat is about the S pouch. And so particularly the question says the S pouch, which is, I guess, the original description, tends to have an increased capacity compared to the J pouch, raising for potential improvement in bowel function. Does the S pouch get used anymore? And have you, I guess, specifically with a single stapled, have you done that with an S?
Yeah, so it is a good question. So the S shape was really popular, I believe, more than 10 years ago, at least in our regions. As a referral center, we have seen many S pouches perform more than 10 years ago with problem of tubing, so that the patient have to tube the pouch to evacuate. So that's the main problem of the S pouch. So this is why the evolution of surgery has brought to the J pouch, which has no problem in emptying. And we had to do a lot of redo pouches because of this problem. And this problem means not a good quality of life for patients.
Thank you. So I guess efferent limb issue.
Yeah.
Now, I think in the interest of time, I'd like to focus on Professor Hassan, and obviously very grateful for everyone's time, particularly his. And we've briefly introduced him in the start of our recording, but specifically I want to ask him to give us a picture about the state of medical care in Italy, state of training in, say, gastroenterology, to help people in America or in Australia try to interpret manuscripts from Italy to compare apples with apples, we have the saying. So I guess my first question would be a brief description of the training pathway to become a specialist, either a gastroenterologist or a sort of advanced endoscopist. How does that happen in Italy?
Yeah, thanks, Vladimir. I guess that the residency is quite similar. We have a 4-year residency where physicians are exposed to clinics and to outpatient IBD or liver in the first 2 years, and then they are exposed to endoscopy. These last 2 years are mostly to get competence in diagnostic endoscopy. You know that now we have very strict quality criteria for cancer prevention. So I guess that is quite common on both sides of the Atlantic that endoscopies coming out from the training are very good in diagnostic endoscopy. Advanced endoscopy is getting a bit more complex because it's very similar to surgery and it's dividing in between luminal, advanced endoscopy, and biliopancreatic. But this is usually achieved after residency by a master or by post-residency additional training that may last in between 1-2 years. So I guess that an advanced endoscopist require at least 6 years to be prepared, and I guess this is quite common in between Europe and US, at least for biliopancreatic endoscopy.
Thank you. Now, I guess the other end, when you have a trained endoscopist, you have to have a center to support that. And so my question is, in terms of private versus public clinics and the funding in Italy for endoscopy services, is it uniform across the country? Is there a significant difference amongst different areas? And the reason I ask that is because we've briefly touched upon personalization of treatment. How does that happen in Italy based on location and funding?
Yeah, so funding, as you pointed out, is essential. Funding drives endoscopy innovation because advanced endoscopy is very expensive. So, for instance, in our region in Lombardia, we have quite a good reimbursement for ESD, something, for instance, that is not like in the United States. So in our center, we perform many more ESD than in other Italian or European region where there is no good reimbursement for third space endoscopy. So somewhat endoscopy is driven by reimbursement. And secondly, endoscopy, similarly to surgery, is a centralizing procedure. So we realize that you cannot do third space endoscopy if you don't have a good volume of at least 100 or 200 procedure per year. So quite spontaneously, there is a centralization in both pancreatic and luminal endoscopy. And if patients live in a region without the center, they move. So for instance, we do a lot of procedure from a region that do not have a good reimbursement, so they are not driven towards this advanced endoscopy. But then Vladimir considered that Europe is totally fragmented. We have a lot of different public, private systems, but you know what? In the long term, the idea is that the excellence of care is quite similar across the country. So maybe it may be difference in the mid, but in the long term, in every European country, you will have the same standard of care.
That is interesting. I guess back to one of the papers, the first paper we discussed, where there was a close relationship between Italy and Belgium. I guess from an academic perspective, is that quite easy to get cohorts from different countries and compare them?
Yes, from academic perspective, yes, despite, of course, we don't have, for instance, a centralized IRB, so each center must have its own protocol, etc. But having said that, there is a lot of collaboration across academic institutions, especially in Northern Europe, because it's somewhat more compact. And there are also countries like the Netherlands, where one IRB applies to all the country. So, for instance, you have a lot of randomized trials from that because it's somewhat very easy to have a multi-center randomized trial. So also the facility to research at academic level explain where the excellence in research at the end goes.
With research, I guess in Australia, where I am now, we have quite a big Asian population. And I have to say, when I operate on Asian patients, I think it's fantastic. Usually they're quite a lot lighter. I think their pelvises are easier. Of course, from an endoscopy perspective, it may be a bit different. But when you compare countries and cohorts, do you think that there's a impact on sort of the patient demographics? Say you mentioned Holland, they're different physically, they're different to Italians.
Yeah, I guess yes, absolutely. For instance, yesterday we were reading the adenoma detection rate in Poland is about 15-16%, and in North Europe it may be 3 times higher. So there are a lot of difference across Europe, especially in between East Europe and West Europe, or between South and North. If you tell me whether this is a genetic or whether this is driven by lifestyle, it's still difficult for me to answer. Of course, there is a westernization of East Europe, but differences are still there. there are still differences in between different populations.
That's very interesting. My last question, and because I want to wrap it up on time, and we've touched upon it briefly, which is AI. AI is very popular. Everywhere I turn, it seems to be AI is the big thing. And I don't know personally if the value is proportional to the excitement, but you being in the cutting edge of sort of advanced endoscopy, what do you see in the next 5, 10 years? What do you think AI will add? Do you think it's a passing fad, or is it, or will it help sort of detection, polyp detection rate, or general intervention?
I think that first for AI, both endoscopy and surgery, is a great opportunity because it is real time. So endoscopists and probably surgeons need AI because when the exam is completed, we cannot go back and look again. So real-time assistance is somewhat unique for endoscopy and surgery altogether. So my guess, Vladimir, is that AI endoscopists cannot afford mistakes. However, I also need to be a bit more ambitious. Software to detect polyp because the prevalence of polyp is extremely high, but we need something more, like for instance, optical diagnosis for T1 cancer. We need better software for Barrett. We need better software for early gastric cancer. So I feel there are still a lot of opportunity for AI implementation. However, the development take much more time because prevalence of polyp is 40%. Prevalence of Barrett is probably 1 per 1,000. Prevalence of early gastric cancer is 1 every 10,000. So there will be more pressure on the companies to invest more to have better software. But I guess that in real-time procedure, AI is going to stay.
All right. Well, thank you very much. I think that that was a very stimulating discussion. I've certainly got a lot to think about, and I'm very grateful for the entire team from your university. I can't wait to have a look at Milan, particularly when I've read about it. It is truly an amazing city. I've been to a few cities in Italy, but not Milan yet, so I'm sure I'll get there at some point. So thank you all again. Our next journal club will be in 1 month's time, where we'll be discussing video recordings through the Didactic video channel about splenic flexure takedown, comparing robotic, laparoscopic, and open techniques. So thank you all.
Thank you. Bye. Thank
Thank
you.
you, everyone.
Thank you.
Many thanks.